Hi, this is KFJ, and I'm taping the lecture for um, the last portion of the GI learning plan, the nursing care of disorders of the gallbladder, liver, and pancreas. First of all, we'll start out with discussing cholelithiasis and cholecystitis. Cholelithiasis is the presence of gallstones within the gallbladder. Stones can vary from by size and makeup, and they can become lodged and obstruct bile flow. When stones are lodged in the common bile duct, then the patient is diagnosed as having cholelithiasis. Cholecystitis, it occurs when there's an inflammation of the gallbladder and is associated with gallstones probably about 90% of the time. Native Americans are genetically more prone to develop gallstones more so than any other group. Hispanic Americans have the next higher likelihood of developing gallstones. The pathophysiology of how gallstones are developed, they occur when the balance between cholesterol, bile salts, and calcium in the bile is altered, and it forms a precipitate. And then the stone kind of grows as layers of cholesterol and calcium and pigment accumulate over the nucleus that forms. Signs and symptoms. Symptoms depend on the degree of blockage. You may see patients exhibiting symptoms such as clay-colored stools that float because of undigested fat content. If the duct is obstructed by a stone, the bile flow cannot occur. That's why you get those symptoms. Other things such as nausea and vomiting, fever, elevated white count also occur with cholecystitis. The pain that the patient complains of is often referred pain to the right clavicle or scapula or shoulder. You may see as the bile backs up into the liver and blood, the patient may become jaundiced. And if the obstruction is unrelieved, it can progress to liver damage. In this diagram from your textbook, you can see that gallstones lie within the gallbladder with an obstruction then of the common bile and the cystic ducts, and therefore that would cause the bile to build up behind that obstruction and could result in liver damage, etc. Diagnosis of cholelithiasis and cholecystitis is based on the following diagnostic exams: ultrasound, computed tomography, endoscopic retrograde cholangiopancreatography, cholecystography, otherwise known as a HIDA scan, and also liver function tests. Again, like I said, these symptoms are pain, nausea, vomiting, indigestion, flatulence, low-grade fever, and jaundice. So the treatment for cholelithiasis and cholecystitis, initially a low-fat diet is recommended, loss of excessive body weight, a restriction of alcohol intake are recommended, and meals are spaced so no large amounts of food are put into the intestinal tract at any one time. That'll prevent the overstimulation of the gallbladder activity. Medical treatment includes giving oral medications that can dissolve the gallstones. If the patient doesn't respond to this therapy, then the patient may have an endoscopic retrograde cholangiopancreatography to remove the stones obstructing the common bile duct. The procedure can visualize the ducts, and it can see the stones, and can, if the stones are too large, remove them from the bile duct. If that can't be accomplished, let's see here, then the surgical procedure of cholecystectomy would be performed. Cholecystectomy can be done either laparoscopically, which is probably the more common of the procedures, where there's 4 little incisions made on the abdomen, and then the gallbladder is removed and brought out through the umbilicus. In some instances, the patient's not a candidate for that, and they may actually go through an open cholecystectomy where there's actually a 2 to 4 day stay in the hospital, and there's an incision that actually is made in the abdomen, and that's where the larger incision is made, and that's where they bring out the gallbladder. And then a T-tube is placed to drain the bile out of the patient's common bile duct. Preoperative care for cholecystectomy, patient would be NPO. An analgesic might be ordered to control the pain, and antiemetics may be given for nausea. IV fluids would be started to prevent dehydration. If the patient's coag times are abnormal, or if jaundice is present, then vitamin K may be administered to improve clotting ability of the blood. Postoperatively, the patient is kept in a semi-Fowler position after he recovers from anesthesia. If the patient had an open gallbladder surgery, again, they would have tubes and drains. If it's laparoscopically done, then they would not have those tubes and drains. As far as complications go, constant irritation of the gallbladder from inflammation and infection may cause a fistula to form. The gallbladder may become necrotic, it can develop gangrene, or it can actually rupture and cause peritonitis. Next, we'll talk about disorders of the liver. First of all, there's hepatitis. There's 5 different types of hepatitis. There's hepatitis A, hepatitis B, hepatitis C, D, and E virus. Hepatitis A and D are the 2 types that are, let's change that again. Hepatitis A and hepatitis E are transmitted via the fecal to oral route. Hepatitis B, C, and D are transmitted via blood and body fluids, as well as sexual contact. Hepatitis B and C are the most serious forms of hepatitis, as they can progress to chronic hepatitis, cirrhosis, liver cancer, and death. Signs and symptoms. Clinical signs and symptoms of hepatitis A tend to have more of an acute onset, whereas hepatitis B, C, and D are slower. So let's see. The 4 phases of hepatitis A are, first, the viral replication phase, where the individuals will have positive blood tests but display no symptoms. The second is the prodromal phase, in which the symptoms such as nausea and vomiting and fatigue occur. Patients are often then diagnosed as having influenza because of the similarity of the symptoms. Then in the icteric phase, this is characterized by jaundice and usually lasts 2 to 4 weeks. The urine becomes very dark, stools may become light, pruritus may occur, and the liver becomes tender and enlarged. And then the 4th phase, the convalescent phase, begins. The jaundice starts disappearing. It usually takes between 2 to 4 months Major complaints are just general fatigue, liver enlargement, etc. Chronic hepatitis B and C patients are more likely to be asymptomatic. The complications of hepatitis, I think we kind of covered that. The most serious forms progress to chronic hepatitis, cirrhosis, liver cancer, and death. And if you look on page 698 of your DeWitt textbook, there is a nice little table there that shows you the comparison between the different types of hepatitis virus. There's a hepatitis A, B, C, D, and E, and they each show transmission mode, incubation period, effective periods, and signs and symptoms. So I encourage you just to review that from your textbook. Diagnosis is made based on physical examination and lab findings. The serologic assays or enzyme immunoassays detect specific antibodies to various types of hepatitis. Then we have liver biopsy can be done, and that's usually done to diagnose chronic hepatitis. And then elevation in liver function tests are also expected findings when the patient has hepatitis. Looking at liver function tests, AST is elevated in the prodromal phase and could go up to 20 times the normal range, and you'll see this start to decrease as jaundice subsides. The ALT is elevated in the prodromal phase, and that also then decreases as jaundice subsides. Then we have gamma glutamyl transpeptidase, GGT, and that is also going to be elevated. Bilirubin will be elevated. ALK phosphatase will be somewhat elevated. Serum albumin will either be normal or decreased as the liver is affected. The serum bilirubin will be elevated, and the prothrombin time will be prolonged, again as the liver becomes more involved. As far as treatment goes, there's no specific treatment for acute viral hepatitis. There are vaccines that are available to prevent certain hepatitis viruses from causing illness. There's other things such as a well-balanced diet to help the liver cells to heal. 4 to 6 meals per day are tolerated, better than the 3 larger ones. Nausea can be treated with Zofran. There can be immunoglobulins given for passive immunity. There can be antiviral therapy administered. They've had some good success in treating some hepatitis C patients with antiviral therapy. The expected outcomes of treatment would be that the patient would maintain body weight within normal limits. They would verbalize lessened fatigue after rest periods each day, and they'd verbalize a decrease in pain. They'd verbalize knowledge of the disease process and self-care within the 2 days of being diagnosed, and that patients would engage in appropriate diversional activities during convalescence because the convalescent period is so very long. Our nursing interventions would be to monitor progress, prevent the spread of infection, teach the family and the patient proper handling of body secretions and proper hand hygiene and limiting of contact, provides psychological support, and again ensure adequate nutrition. We'd also have to consider the home for different types of viral hepatitis. How do we prevent that from occurring in the home? Standard precaution guidelines, and also infection control. Okay, next let's take a look at cirrhosis. There are different types of cirrhosis. There's the post-necrotic cirrhosis, which is caused by a viral hepatitis or toxic substances, parasites, or infection. The linaic cirrhosis or portal cirrhosis occurs from alcoholism. Excessive alcohol ingestion causes deposition of fat in the liver cells. The condition is reversible if alcohol consumption is halted. Otherwise, widespread scarring is going to occur. Then we have biliary cirrhosis, which is caused by chronic biliary obstruction and infection, and cardiac cirrhosis, which results from severe right-sided heart failure in patients with cor pulmonale. Here you see the signs and symptoms of cirrhosis. This picture is in your textbook on page 707. You'll see under neurologic signs and symptoms, there's hepatic encephalopathy, peripheral neuropathy, and asterixis. In GI, there's anorexia, dyspepsia, nausea, vomiting, change in bowel habits, a dull abdominal pain, fetor hepaticus, which is also known as the breath of the dead, esophageal and gastric varices, gastritis, hematemesis, hemorrhoidal varices, amenorrhea, testicular atrophy, gynecomastia, and impotence as far as reproductive goes. Under integumentary, you'll see jaundiced spider angiomas, palmar erythema, purpura, petechiae, caput medusae. Hematologic, you'll see anemia, thrombocytopenia, leukopenia, coagulation disorders, splenomegaly. Under metabolic, hypokalemia, hyponatremia, hypobilirubinemia, cardiovascular, fluid retention, peripheral edema, and ascites. Diagnosis of cirrhosis is made based on the results of a liver biopsy. There are liver function studies, a CAT scan and liver scan, a magnetic resonance cholangiopancreatography. The treatment for cirrhosis is to stop the liver damage and try to restore the liver's function as much as possible. Symptoms of cirrhosis: fatigue, weakness, headache, anorexia, indigestion, abdominal pain, nausea, and vomiting. Fluid retention, especially ascites, excessive gas, skin rashes, itching, and fever. Leg and foot edema and palmar erythema, caput medusae, and bleeding and bruising. Patient has deficiencies in vitamin K and thrombin and prothrombin, which can interfere with clot formation. The liver is often enlarged and knobby, so you should be able to palpate it below the rib cage on the right hand side. They may complain of abdominal distension. Their spleen may also be enlarged. They have peripheral edema and ascites, skin lesions, jaundice, itchiness, bleeding disorders, endocrine disorders, peripheral neuropathy, spider angiomas, and angiomas that may blanch with pressure. For our nursing care, of course, we're going to assess for safety issues related to change in mental status. The patient may have signs of bleeding. Pay extra attention to ammonia levels, albumin, AST, ALT, and protimin INR results. Increased ascites is determined by measuring their abdominal girth on a daily basis and daily weights. If alcoholism is an issue, watch for signs of withdrawal, which may occur 6 to 12 hours after the last drink and continue for at least 3 to 5 days. Okay, some of the nursing diagnoses that you may see are actual or potential for altered breathing pattern, or altered gas exchange due to fluid accumulation in the chest or the abdominal ascites. They may have a potential for bleeding due to esophageal varices and decreased clotting factors. They may have acute confusion due to increased ammonia levels, risk for injury due to confusion, inability to perform self-care due to drowsiness or fatigue and ascites, excess fluid volume due to ascites and peripheral edema from portal hypertension. So those are our main diagnoses, and our interventions then would be pretty much keeping the patient safe, because they are at risk for so many problems. And then of course the evaluation would be, did we keep the patient safe? Did we meet their need for performing ADLs, and can we keep their fluid status under control, that they're not retaining too much fluid? Complications of cirrhosis, again, the esophageal varices, kind of like varicose veins of the esophagus. They are formed because of portal hypertension. They can cause major problems because they can actually rupture and bleed, and the patient it could be a life-threatening condition where they're bleeding from their esophagus. Can be treated with upper endoscopy. They may be able to clip the esophageal varices, or they may be able to sclerose them so that if they are bleeding. Another complication is the encephalopathy. Patients may develop delirium, convulsions. They may go into a coma. Ascites, as far as medical treatment for ascites, they may be started on diuretics. They may be given albumin intravenously because the liver can't manufacture it on their own. There may be a paracentesis done, or the patient may have a peritoneal venous shunt placed so that it can circulate the ascites fluid from the abdomen back into circulation so it can be excreted via the kidneys. As far as bleeding esophageal varices go, like I said, there could be drug therapy, sclerotherapy, surgical ligation, or placement of an esophageal gastric balloon tube, which would provide pressure to the bleeding varices and they would clot off. This is just a picture of the peritoneal venous shunt that's placed in the abdominal cavity to circulate the excess fluid back into circulation. And that's an example of a Sangster Blakemore tube that has the NG inserted down to where the esophageal varices are. The balloon is then inflated and it applies pressure to the varices so they don't bleed. The only real cure to liver disease is liver transplant. And if that occurs, then nursing management, of course, would be managing the chance for infections. The patient would be at risk for infections because the patient would receive immunosuppressant therapy. Of course, then the liver function tests would be done to monitor whether the transplant is working, functioning normally. Inflammation of the pancreas is otherwise known as pancreatitis. It's frequently accompany obstruction of the pancreatic duct from gallstones. Many cases of pancreatitis are related to alcoholism as well. It can be caused by viral infection, trauma, ERCP, penetrating ulcers, drug toxicity, metabolic disorders, and a variety of other factors. Men tend to develop pancreatitis related to alcohol. Women tend to develop pancreatitis associated with gallstones. In some types of pancreatitis, there's a severe inflammation and damage causes the escape of pancreatic digestive enzymes, and these enzymes then act directly on the tissue, causing hemorrhage and autodigestion of the pancreas as well as necrosis. It's not really clear how the autodigestion is activated. Alcohol can cause a spasm of the sphincter of Oddi, which blocks secretion through the pancreatic ducts, and this can lead to activation of the pancreatic enzymes within the pancreas. A pancreatic abscess or pseudocyst may develop as a result of pancreatitis. A pseudocyst is a sac-like structure that forms on or around the pancreas, and it can contain actually several liters of enzymatic pancreatic exudate. If the pseudocyst ruptures, it can cause a hemorrhage, and shock may occur. Signs and symptoms of pancreatitis is abdominal pain. The pain is steady and localized in the epigastrium or left upper quadrant. As it progresses, it spreads and radiates to the back and the flank. Sitting and leaning forward may ease the pain. Eating makes it worse. Nausea, vomiting, sweating, jaundice, and weakness often accompany the pain. The abdomen will be tender. If peritonitis is present, the abdomen will be distended and rigid. Bowel sounds may be reduced or absent. If retroperitoneal bleeding is present, there may be bruising in the flanks. Diagnosis is made based on the symptoms, risk factors, and results of tests that are performed to rule out other disorders. An abdominal ultrasound and CAT scan may be done, and serum and urine amylase studies are usually ordered. Treatment for pancreatitis, pain evaluation and control, vital signs are monitored. Observe for signs of restlessness. Monitor lab values and note changes. Monitor IV fluid administration and monitor for electrolyte imbalance. Patient is kept NPO during the acute phase. A nasogastric tube may be placed. If the patient is receiving TPN, because the patient's NPO, blood glucose levels may need to be checked. Then after the acute episode, the patient may resume food, so we need to assess for a tolerance to the diet. If there's a pseudocyst present, it will be surgically drained. So intravenous meperidine or morphine will be used to control the pain via PCA. Histamine receptor antagonists or proton pump inhibitors may be ordered to decrease the hydrochloric acid secretion that stimulates the pancreatic activity. Here's a picture of, the healthier pancreas is kind of more to the right, and then you'll see the inflammatory lesions and the area just below the duodenal ampulla. And here's the concept map of the pathophysiology of acute pancreatitis. So the precipitating factors are the alcohol consumption, the biliary tract obstruction, cancer or in some cases the mumps virus. And then the activation of the pancreatic enzymes inside the pancreatic ducts lead to autodigestion of pancreatic tissue, which leads to tissue necrosis and severe inflammation of the pancreas, which results in enzymes and cell contents leaking into general circulation, which can cause shock, disseminated intravascular coagulation, or adult respiratory distress syndrome. Or it can also result in active enzymes leaking into the peritoneal cavity and continuing to destroy tissue with massive inflammation, which would result in severe pain, hemorrhage and shock, peritonitis, and hypovolemic shock. Okay, so our first question revolves around the nurse discussing disease prevention measures to a group of older adults during a senior seminar. Should include which of these instructions? Select all and apply. Consume sufficient fiber, eat a normal diet, well-balanced diet, exercise regularly, drink at least 3 glasses of fluid a day, or take laxatives regularly. If you want to put this on pause and answer the question, and we'll go over the correct answers in just a second. The correct answers would be 1, 2, and 3. 4 is not enough fluid per day, and 5, taking laxatives regularly is a bad idea. Number 2, an elderly patient, female patient of Puerto Rican descent was admitted for persistent anorexia and dehydration, with no apparent organic underlying cause for loss of appetite. Which actions should be culturally appropriate? Select all that apply. Determine food preferences. Encourage the family visits. Let's see. Whoops, sorry about that. Provide warm beverages with meals. Consider parenteral nutrition, or consult dietitian and speech therapy. Again, the correct answers would be 1, 2, and 3. Next question. Regarding the care of enteral feeding tubes, which nursing behaviors demonstrate appropriate nursing care? Select all that apply. Aspirating contents of the jejunostomy tube, gentle flush of the clogged enteral tube with 30 ml of water, checking for a 1-inch play on the gastrostomy tube, monitoring BUN, prealbumin, hematocrit, electrolytes, and glucose, or rotating a jejunostomy tube 360 degrees each day. The correct answer for this question are 2 and 4. And then the recommended diet for patients with inflammatory bowel disease include a combination of low fat, high fiber, high protein, low calorie, lactose avoidance. And the correct answer for this question would be 1, 3, and 5. Which statements regarding Crohn's disease would be considered true? Select all that apply. It affects the full thickness of the small intestines. It manifests as bloody diarrhea with abdominal cramping. There is a cobblestone appearance in the x-rays. Pseudopolyps are found on the affected segments, and there's a greater risk for colon cancer. And the answer would be 1 and 3.